Thank you very much, Marina. Good morning, everyone. Thank you for getting up early on a Sunday morning when probably you would have liked to sleep in. I hope you don't regret to be here early on a Sunday morning. I certainly don't regret to be here. I'm really happy to be here. I was absolutely amazed yesterday from the interaction with the pediatricians that I met. I saw such a positive spirit and so much enthusiasm. I was also able to visit the city and had the same impression. There was so much positive energy that I was really happy to be here. So my topic this morning is nutrition in early childhood. It's a very, very broad topic, so I cannot cover everything, but I'll try to give some of my thoughts on some of these aspects. But I just want to emphasize again, I'm not standing here on my own. I'm standing here on behalf of the European pediatric community, which is with you in spirit and thoughts. You're not alone. The pediatricians of Europe are on your side. So these are my disclosures. So these are the topics I would like to discuss with you: the concept of early metabolic programming of health effects associated with breastfeeding, the variation of human milk composition and impact, the effect of infant protein supply on health, particularly obesity, role and timing of complementary feeding, and particularly the impact of allergy risk. So let's go through this. Pediatrics is characterized by the dynamics of growth and development. That's our key topic. Everything changes in pediatrics all the time. And of course, nutrition is an important factor in here. The Chinese have this amazing idiom. They say the first 3 years determine the life until old age, until the age of 80 and beyond. And I think every pediatrician will agree. We know how critical early development is, how critical tender loving care of the parents, of the family is, and any other way of support for shaping the future of a child. In science, we have substantiated that concept of the first 3 years with the term of the first 1,000 days. We have found a lot of evidence that environmental cues, including nutrition and metabolic signals, during these first 1,000 days of pregnancy in the first 2 years of life, in particular, have a lasting effect on the growth, the physiology, the structure of the organism, and long-term health and disease risk. Because it's a period of high developmental plasticity. In other words, the organism can go into different directions of its development, and the environment, including nutrition, shapes how the organism is developing. And it's like when you buy a computer, the way the computer works depends on how it's wired, how the different connections are made when it's built. And the same goes for a child. The way how the organism is structured in early life will depend how it works lifelong. So clearly for us, breastfeeding is the best way to feed a baby. It's a natural way of feeding a baby. It has developed over millions of years of evolution to meet the needs of both infants and the mother. And we know it not only provides nutrition, but also it provides non-nutrients that have functional effects. I'll show you some examples further on. It supports growth, health, and development. And we shouldn't underestimate that also the way of feeding is very important. It supports the bonding of mother and baby, which is really relevant for child development. So in our work, we should do everything we can every day to promote, protect, and support breastfeeding. I really like this old poster, which says, "Nurse the baby, it's your protection against trouble." Very true. And I also particularly like the last line, "Ask your doctor. Don't believe everything you read on the internet, but really trust in your doctor. The doctor is the one who gives you the best advice. So we should repeat that message all the time, that the pediatricians are the ones who can answer the questions. So all over the world, there's unanimous agreement, breast is best. There's nothing really to discuss here. And we all know about the multiple benefits of breastfeeding. We know that breastfeeding is not one and the same as we do with the infant formula, but it changes with the age of the child. For example, you look at the protein intake. At 6 months, the protein supply with breastfeeding is only half of what it is after birth, and it perfectly matches to the different speed of growth of the baby and the different nutrient needs. Also, there is an adaptation of the nutrient supply with the individual baby, because the baby signals, particularly the suckling, determine not only the volume of human milk delivered, but also the nutrient supply. It obviously supports normal growth and development. It protects against infection, particularly if you have a high risk of infectious disease. It protects long-term health. For example, it reduces the risk of obesity. It has a positive effect on brain development and cognitive function. It has a high level of safety. There's no adulteration. It's always fresh and well temperatures. It doesn't need preparation. It has variable flavors because the taste and smell of breast milk changes with what the mother eats. If the mother eats garlic, the baby is exposed to garlic. And again, this is very different to feeding a bottled milk, which is one and the same for 6 months. But with human milk, the baby is exposed to different flavors, and we have studies showing that this facilitates the introduction of complementary feeding as well. It's environmentally friendly, has a low CO2 footprint, doesn't have a cost of purchase, even though the mother needs to eat a little bit more. And again, it promotes bonding. A number of studies have reported that breastfeeding is associated with a considerable risk reduction for infections, particularly diarrhea and otitis, but also upper and lower respiratory tract infections. But mind you, this is really depending on the condition of the child. So it's very strongly visible in conditions of poor hygienic circumstances. You have a high infectious disease risk, lots of crowding, unsafe water, contaminating foods, then you have large effects. But if you have less infectious risk, like in Europe, we will see this effect is not so strong. But all over the world, there is also an association with less disease risk later. Atopic dermatitis, inflammatory bowel disease, Crohn's disease, and ulcerative colitis, diabetes 1 and 2, obesity, all were reported to have a reduced risk in children that were breastfed compared to those who were not. And you see, it's any breastfeeding or 3 months of exclusive breastfeeding or 3 months of non-exclusive breastfeeding. So all kinds of breastfeeding matter. It's also an important message for women who cannot breastfeed for long exclusively. Any breastfeeding is valuable, and any breastfeeding can help to reduce risk. And this is particularly impressive. This is a meta-analysis from the World Health Organization showing that on average, there's a small but detectable benefit on later intelligence at school age. Even if you adjust for maternal IQ, there is a measurable difference, 2.2 IQ points more with breastfed than with non-breastfed babies. Well, you may say, 2 IQ points, is that important? I cannot measure that in an individual child. If I look at this room, here we probably have an average IQ of at least 150. Whether you have 150 and 152 probably doesn't decide on your happiness in life. But remind you, if you shift the whole population by 2 IQ points, you also reduce the number of children on the low side, where it really matters, who have a very low IQ. So I think it could really have a matter. But of course, we don't know from observational study whether there's residual confounding, there's other factors associated with the decision of breastfeeding that matter. But we think there's also milk components like the long-chain polyunsaturated fatty acids that are relevant for this outcome. Now, this is just a selection of the bioactive components that have been discovered in human milk. And you see, it's a very, very long list. And it's amazing to think about it, that in human milk, we have living immune cells, we have a variety of immune factors, immunoglobulins, interleukins, we have growth factors, we have hormones, we have all kinds of components that do much more than just providing nutrients. So we just should think of human milk as something very precious that has a lot of biological activity. And what is absolutely fascinating is that human milk is personalized nutrition, if you like. We have this enterobronchomammary system where the antigens that reside in the respiratory tract and the gastrointestinal tract of the mother imprint the B cells in the mesenterial lymph nodes and the hilal lymph nodes of the respiratory tract, and thereby in the breast, specific antibodies are produced, SIgA antibodies, that are targeted to those bacteria that are residing on the mother and that are the ones that will first colonize the newborn baby. So the antibodies in Lviv will be different from those in Munich or in New York. The mother has a specific protection against the pathogens around her for her baby. Isn't that fascinating? Personalized nutrition, if you like. We should not only think of single components, because breastfeeding is a very complex biological system with a three-way interaction between the mother, the milk, and the baby. So mother's biological determinants like the genes, external factors like her diet, her environment, infections, and bacterial exposure, as well as the infant aspects, suckling, genome, many others, interact. And it's also an interaction of many different components who work in concert. It's like a symphonic orchestra. If you just take one instrument, you won't be able to repeat what the whole orchestra can do. So the interaction of components and factors modulates biological effects. So be careful if somebody says, we have now this new infant formula and we have the magic component added, and now it's like breast milk. That's not going to be working because, you know, we cannot replicate breastfeeding with a single component. I just want to go back in history and show you how important breastfeeding was in Europe for child health. This is a statistics from Germany in the 19th century, where they calculated infant deaths by 10,000 children over the first 10 months of life. And you see that children who were not breastfed had about a 7-fold higher mortality until 10 months than those who were breastfed. And you can also see that if the mother was married, it protects the baby from mortality. Now, it's not the act of wedding that protects, but it's probably the unmarried mothers were the ones with lower socioeconomic status and more risk factors. So today, I'm not sure that going to the wedding will change the outcome of your baby. But anyway, the effect here is absolutely impressive. And it was an important public health message then in Germany. If you breastfeed, you reduce the risk of your baby to die in the first year of life. Very impressive. But then, of course, it was a very different situation in Germany 100 years ago. And we didn't have good alternatives to breastfeeding. So babies were typically getting animal milks, unmodified goat milks, which of course we know is not suitable for feeding babies. And people went so far as to feed a baby even directly from the goat. So for a long time, the only safe alternative for breastfeeding was a wet nurse. For example, already 1,000 years ago in Persia, Avicenna wrote, obviously, breast milk is the best for the child, and if the mother cannot breastfeed, you should find a wet nurse, and they had a very clear description. Should be young, 25 to 35 years, healthy, of good and honorable manners, and having given birth 1.5 to 2 months before. Now, the last line, I think, is very impressive. 1,000 years ago, they already knew that the breast milk changes over time. And it's the same problem now with donor milk from breast milk banks. If it collects breast milk from donor mothers at 5, 6 months after birth, it's much diluted in nutrient content compared to early milk. So amazing that they knew this already at that time, around 1,000 years BC, AD, that you need to have a wet nurse early after birth to have a good outcome for your baby. That was very common in Europe in the 18th and 19th centuries, in these cities, probably same in Kiev. People employed wet nurses from the countryside, poor women who came to the cities to breastfeed the babies of other families. So you see here, end of the 18th century, more than 80% of the babies in Paris were nursed by a wet nurse. There were about 5,000 wet nurses employed in the city of Hamburg alone. Amazing what happened there, because people knew if you try to feed with goat milk, your baby is not going to have a good outcome. And even the hospital that happened, this is the hospital where I trained in my pediatric residency in Düsseldorf. In the beginning of the 20th century, they employed wet nurses even at the hospital to feed the babies in the hospital. And there's a wonderful report from the director of the hospital who was complaining how unreliable the wet nurses were, because they were paid by the amount of milk they delivered. So the babies were test fed before and after nursing by the wet nurse. And the hospital director was complaining that they would feed extra water to the baby to increase their payment. So they were having a lot of difficulties. So the worldwide recommendation of the World Health Organization is, since 2001, since 25 years more or less, that on a population babies should be exclusively breastfed for 6 months as the optimal infant feeding way, in brackets, but they also wrote some infants benefit from introducing complementary feeding earlier, if you read the WHO text. And thereafter, infants should receive complementary foods with continued breastfeeding up to 2 years or longer. Now, that's not really what we see in Europe, and so we'll come back to what is our conclusion for women and babies in Europe. The main reason for this was the reduced infectious disease morbidity and mortality in low and medium income countries, where they estimate improved breastfeeding practices might prevent infections and 12% of deaths in children under 5, a huge number of deaths in low-income countries. And the reasons, again, are the anti-infective effects of breastfeeding and the protection against early contact with unclean water and contaminated food. So very important in poor conditions to have that recommendation. The question, though, is the concept of having one and the same recommendation for the whole world, is that best? Because the conditions are different in Europe, in Ukraine, than in Malawi, right? You have a very different risk of infectious disease in a European country and in some of the low-income countries. So let's look at the data. This is an impressive study because it's the only randomized clinical trial I know that assigned infants after birth to breastfeeding or no breastfeeding, something that people say you cannot do. In Kenya, they did it because they wanted to know, is breastfeeding associated with the risk of vertical transmission of the HIV infection from mother to baby? So they actually randomized babies to breastfeeding or non-breastfeeding. And under the conditions of Kenya, they had taken great care for safe formula feeding with detailed demonstration of safe preparation, using of boiled water, and use of cup feeding. Now, doing that, there was actually no difference, even in Africa, between breast and non-breastfed babies for infections. Now, how is that in Europe? This is a very large study from Europe, from Norway. More than 70,000 babies, a mother and child study in Norway. And they looked at infections treated at hospital during the first 18 months of life. And you see here, age of solid introduction does not change the risk of infection. With early introduction of solids, there's no increase of the risk, or rather a trend to a decrease, but it's not significant. So in Europe, the time of introduction of complementary feeding does not change the infection risk. So whether you breastfeed or not matters, but whether you breastfeed mostly or you whether breastfeed exclusively doesn't change the risk of infection. There's this comparison also of bottle and breastfed babies, a sizable study over 1,000 babies. And you see in this study in different countries, Austria, Germany, Italy, Netherlands, Switzerland, there is a very low risk of infection. Days of fever is a very low number. There's absolutely no difference between the breastfed or non-breastfed babies. So it's important to remember breastfeeding is best, but it's not a matter of life and death in Europe. It's not a matter of serious infections in Europe when you have a low infectious disease risk. Now, most of the infants around the world are not exclusively breastfed for 6 months. Wherever you go, the WHO recommendation of exclusive breastfeeding of 6 months is not reached by the majority of babies. And particularly in Europe, if you look at here, France, Germany, Italy, the Netherlands, it's around less than 20% of babies in Europe that are exclusively breastfed for 6 months. So what do we make out of that? Should we tell all the mothers, you are bad mothers because you're not breastfeeding for 6 months? Is this the right message? Do they do everything wrong? This is the timing of introduction of complementary feeding in 5 European countries that we studied. In the formula-fed babies, it's almost all babies who get complementary feeding across the countries before 6 months. In the breastfed babies, it's almost 90%. I'm not sure what it is like in Ukraine. Is it similar in Ukraine? You don't say anything? Basically, all babies get complementary feeding before the age of 6 months. And I'm asking, is it the same in Ukraine? Yes, okay. But it's also the national recommendations. We did a survey together with the World Health Organization Europe and asked what are the national recommendations for introduction of complementary feeding, earliest age, ideal age, latest age. And 82% of the national recommendations across the European countries said complementary feeding before the age of 6 months is supported in the official national recommendations of infant feeding. In Germany, we have a similar recommendation. This is our national recommendation. The best form of nutrition for babies in the first months of life is exclusive breastfeeding. Babies should be breastfed in the first half year of life and exclusively for at least until the beginning of the 5th month of life, so for a duration of 4 months. And we also say any breastfeeding is beneficial and should be encouraged. Okay, so if babies are getting breastfeeding not exclusively for 6 months, but they get complementary feeding earlier, is that a disadvantage or could there be benefits of the earlier introduction? Why are all these babies getting complementary feeding earlier? Do the mothers not read the WHO recommendation? Or is it signals from the baby, interaction between baby and mother that matter? The traditional concept of complementary feeding, in Germany we call it Beikost, which means not weaning food, but foods that you give in addition to breastfeeding with the message, start complementary feeding and don't stop breastfeeding. The old recommendation 100 years ago was from the second half of the first year, you need to give complementary feeding because exclusive milk feeding alone does not suffice anymore to provide the nutrient needs and may even cause health damages. And I'm sure all of you have seen babies that were breastfed only for more than a year and go into iron deficiency and malnutrition. We all have seen such cases. So iron is a very important topic here because babies are born with very good iron stores, depending, of course, also on the conditions of parturition. Do we have late cord clumping, which contributes to providing more iron to the newborn? But then with the very rapid growth towards the end of the first half year, the iron stores become depleted. And babies need additional iron because breast milk has a very low iron content, which evolutionary is beneficial to protect also the mother from iron deficiency. This is a study that my doctoral student Orapon has done. She has done a prospective study in more than 100 mother-infant pairs and studied them in the first months of life. And she found that infants that were fully breastfed at 4 months had a surprisingly high number or proportion of zinc deficiency and also iron deficiency already early on. Iron, as we all know, is the most common micronutrient deficiency in children. It has not only an effect on hemoglobin, on anemia, but also it has an adverse effect if you don't provide enough iron on brain development. The iron stores that you have at birth are used up during the first half of the year, and then after the age of about 6 months, you have a high iron need of around 1 milligram per kilogram a day or more. And if we provide cow's milk, the iron from the food is not well absorbed. Cow's milk has an effect on reducing iron absorption also from other foods, as well as some other dietary components. If we provide meat or fish or vitamin C, we, on the other hand, enhance iron absorption. So one important strategy to protect iron stores in babies is to try to avoid unmodified cow's milk as a drink in the first year of life because it increases the risk of iron deficiency, and whenever accepted, provide meat and fish as a good source of bioavailable iron and zinc. And in fact, many studies have shown benefits. It's a study from the UK who shows that the amount of meat provided from 4 to 12 months not only predicts weight gain, but also psychomotor development. If you provide more meat, psychomotor development was beneficially affected. Iron deficiency clearly affects brain function. This is a study for a complex task, an object permanent task, performed at the age of 9 months. Iron sufficient babies perform best. If you have iron deficiency without anemia, then the development is adversely affected. And if you have iron deficiency, anemia, it's even worse. So iron deficiency affects brain function in babies. But what's more, it also has a lasting effect many years later. This is the cognitive score, the IQ score in adulthood. And you see with iron deficiency, you have a lower cognition than with iron sufficiency. And interestingly enough, if you have a low socioeconomic status, the adverse effect is greater. So if you have a good stimulating environment at home, you have parents who can read books to you, who give you a good compensation, then the iron deficiency effect can be to some extent compensated. If you have a poor socioeconomic environment, the iron deficiency effect can be to some extent compensated. If you have a poor socioeconomic environment, the iron deficiency effect is greater. So it's not iron alone, but it's iron together with other factors that affect development. We can protect infants by providing iron with providing meat, fish, or iron-enriched foods iron-enriched cereals, iron-enriched formula. And you see here in children up to 5 years, it's effective in this meta-analysis. It improves hemoglobin. It reduces anemia by about 1/2 if we provide good sources of dietary iron. It's actually more effective than the effects of iron supplements, iron drops in a Cochrane analysis. That's really amazing. And perhaps it's because iron supplements have more adverse effects and then they are discontinued, or it's simply because families find it difficult to give iron drops day by day, to think of that. But an iron-enriched food, of course, you give to the baby day by day. Another aspect of introducing complementary feeding is the signs of maturity and the signals between mother and baby. And I'm convinced that is very important. From our own study, we did one study where we measured the energy intake of babies at the age of 3 months before introduction of complementary food and related this to the time of introduction of complementary feeding. And what we find is that the children who have a high energy requirement at 3 months take complementary feeding earlier. And for me, that means the mothers, the parents, realize the baby is asking for more. The baby is hungry and wants more, is not satisfied with milk alone. So it's not only a decision of the parents, it's the interaction of parent and baby. So signs of maturity for complementary feeding, you know them all: head or trunk control, sitting upright, the oral response pattern, opening the mouth when food is offered, maturation of tongue and lip movements, foods can be removed from the spoon, fine motor skills in the oral cavity, hand-to-mouth movements, interest in the food of others. The baby is looking at what others are eating and is signaling, I want this as well. All right, so fully breastfed infants are not one and the same. We all know that. There's variation among the infants that are breastfed. And we all have seen infants that are fully breastfed that do not grow well, and we see infants that have an excessive weight gain during full breastfeeding. So why is that? Well, one reason is that the composition of breast milk is extremely variable. You see here the protein content as one example. It all goes down over time, but within each time point, you see there's enormous differences in the protein content between different mothers' milk. A lot of inter-individual variation. And interestingly enough, that is related to weight gain. And we can see it if we look at the milk of different species. Humans have a milk that is very low in protein compared to other mammals. And you have a very long time of doubling birth weight, 180 days. Our babies grow much slower than the babies of other mammalian species. Look at the cow. The cow doubles its birth weight, the calf, in about 50 days and has 3 times as much protein in cow's milk than humans have. And we are nothing against dogs, cats, and rats who have much higher protein content in the milk and very fast growth of their offspring, very rapid weight gain. So clearly protein provision is very closely related to the speed of growth. And in fact, that was shown in human studies. This is a study of more than 600 mother-infant pairs, where human milk protein was measured in one sample at 1 to 2 months after birth. And you can see that the amount of human milk protein in one sample predicted the body mass index at 1 year of age. Isn't that amazing? A single protein measurement in human milk predicts how the baby grows over the first year of life. So clearly, it shows that the protein content is determined by each mother. It has a track record. It's a biologically determined factor in her breastfeeding pattern, how much protein she delivers. Now, the weight gain early on is important because a higher weight gain in infancy predicts a later risk of obesity in childhood, adolescent, adulthood. If children get have a high weight gain in the first year of life, their overall risk for later obesity is doubled, adjusted for other confounding factors. So we followed for a number of years now this hypothesis, the early protein hypothesis, and we thought that a high intake of early protein increases not only weight gain in the first year of life, but also the risk of later obesity, the new health epidemic of our children in the 21st century. And in fact, if you look at the difference between bottle-fed and breastfed babies, bottle-fed babies have a higher energy intake at 3 and 6 months, 15 to 20% more energy, but they have a particular difference in the nitrogen intake, the crude protein intake, the total nitrogen intake at 3 and 6 months is 1.6 or 1.8-fold higher than in breastfed babies. So we thought this high protein intake could increase the blood and tissue concentration of the amino acids that release insulin and insulin-like growth factor, thereby enhance weight gain, body fat deposition, and the risk of long-term obesity and non-communicable diseases. And in fact, we performed a large study now 25 years ago in Bavaria in the south of Germany, where we looked at overweight and obesity at school age in more than 9,000 children. And you see that children who are breastfed have a lower risk of overweight and obesity than those who were non-breastfed, adjusted for many, many confounders. Overweight was about 20% less risk, obesity 25% less risk if you were breastfed compared to non-breastfed. So that's a very important benefit of breastfeeding, clearly, to reduce long-term risk of obesity. And what is perhaps even more convincing is this dose-response relationship. The longer the children had been breastfed, the lower was the obesity risk. That's not exclusive breastfeeding, that's any breastfeeding. Longer breastfeeding protects more against later obesity. And all the time when you have a dose-response relationship, you think, yes, that's compatible with a cause and effect relationship. And that was replicated in many meta-analyses around the world. You see here 5 meta-analyses. They all show breastfeeding is associated with less obesity risk later, between 12 and 26% risk reduction. So on a public health perspective, if you can prevent 1 in 8 or even 1 in 4 cases of obesity in Ukraine with improved infant feeding, what a huge benefit is that? For the huge benefit for not only the people, but also for the healthcare system, for the cost of obesity and related disease. So clearly, we need to tell this to our politicians every day. If you invest in early life, if you invest in promoting child health, you have a huge benefit for the population health and for the cost of healthcare. It's a message we really need to get into the brains of our politicians. Well, we followed this question, is it the protein that we provide? And we performed a large study that the European Union funded through its research program, where we enrolled more than 1,600 healthy babies across 5 countries, including Poland. We had more than 500 children that were exclusively breastfed for a minimum duration of 3 months. And you know, with breastfeeding at the beginning, you provide about 1 to 1.2 grams of protein per 100 milliliters. And then we had more than 1,100 children that were randomized, double-blind, at a median age of 2 weeks to either conventional formula, rich in protein, infant formula with 2 grams, follow-on formulas with more than 3 grams of protein, or an intervention formula that was reduced in protein content, more similar to breast milk, but had the same amount of calories per 100 milliliters. The formulas were provided for the first years, and then we followed up the children until later. And what we found was, first of all, the lower protein provision was completely safe, completely normal length growth, neurodevelopment, all other safety markers were just fine. but we had a big difference on growth. If you look at the mean body mass index after feeding, the feeding was only different in the first year. At 2 years, at 6 years, we had a persistent effect on the body mass index, on the risk of obesity. The breastfed babies are in green. The high protein formula babies fed in the first year had a significantly higher body mass index. But just with reducing protein alone, we get closer to the effect of the breastfed babies. And if we look at the high percentiles, the overweight and obesity groups, then we see a much larger effect. And therefore, if we look at the risk of obesity at school age at 6 years, you see the risk of obesity is reduced 2.6-fold just with improved infant feeding, with providing less protein in the first year of life. A huge effect size, 2.6-fold less obesity at school age. That's better than anything else that we have tested in terms of prevention of obesity in children. It's a huge benefit. So again, investing in early childhood is really worthwhile. It's not only the body mass, but it's also the body fat, which is really the factor that makes us sick. The body fat content is the predictor of insulin resistance, of diabetes, of cardiovascular risk. And you see in red, the children that were fed the high protein conventional formula in the first year of life, they have a higher body fat at 4 years, at 6 years, than the children who had been breastfed, who had been fed a low protein infant formula. And the effect persists into early adolescence. At 11 years, we can still see the effect. And as we speak, we are now trying to find these children again and look at them at the age of 19 and 20 years and see whether in adulthood we can still see effects of infant feeding. So it's important to avoid high protein intakes. If we have a child that is fed a bottle milk, we want to go for a bottle milk that is closer in composition to human milk, that has closer levels of protein. But it's also important to avoid cow's milk in the first year of life as a drink. I told you before, cow's milk has 3 times as much protein as human milk. And you see in this study from the UK, infant feeding at 8 months predicts weight development until school age. The children who are heaviest at 10 years are the ones that consume a lot of cow's milk in the first year of life. So it's not only important for iron status, it's also important for healthy weight gain to avoid cow's milk as a drink in the first year whenever possible. Because cow's milk, again, has 3 times as much protein as human milk. It's made for cows, it's not made for babies. No cow's milk in the first year is a message we try to get out to families to tell them this is made for cows, not for your baby. Last point is infant feeding related to allergy risk. We all are confronted with a markedly increased prevalence of allergies now than decades ago. It's become a new epidemic. A lot of our children have different forms of allergic reactions, hay fever, eczema, asthma, and we have seen it increase over the years quite markedly. Many women believe if I breastfeed and breastfeed long, I protect my child against allergy. But unfortunately, we don't have any data to really support this. The published results are very inconsistent and controversial. We have no conclusive evidence that breastfeeding reduces the risk of allergy or asthma in infancy. The problem is also the observational studies cannot really show causalities. There's a lot of confounding and residual confounding. Many women who see a skin rash think I should rather continue breastfeeding for longer to protect my child. So you have the reverse relationship between allergic symptoms and longer breastfeeding. So it's very difficult to answer, but again, we have many other good reasons for breastfeeding, so that should not discourage us from supporting breastfeeding. A systematic review here from the European Allergy Guidelines shows breastfeeding not to be reducing the risk of food allergy or cow's milk allergy. Breastfeeding and asthma meta-analyses do not show an effect also on asthma risk. So we have to be realistic. We will not have a marked effect on allergy and asthma through breastfeeding. There's also a randomized clinical trial that was performed many years ago in Belarus, the PROBIT study, where the investigators randomized hospital to enhanced breastfeeding promotion or not. And in Belarus, that really improved the rate of breastfeeding, the duration of breastfeeding. There was a clear effect of breastfeeding promotion in hospital on the breastfeeding activity. As you see here, this is the breastfeeding rate and the exclusive breastfeeding rate, but it had absolutely no effect on allergy and asthma at later ages. Longer breastfeeding, more breastfeeding did not reduce allergy and asthma. The question then is, do we need to look at this in a more complex pattern? Because breastfeeding alone has outcome will not give us the answer, perhaps, because it's an interaction with genetic variation and environment. Again, breastfeeding is not one and the same in all mothers and babies. So we looked at that in a study in Germany where we looked at the genetic polymorphisms in the enzymes that mediate the metabolism of the polyunsaturated fatty acids. There is in all of us about 500 single nucleotide polymorphisms in this gene cluster that determine how well we can convert the essential fatty acid linoleic acid to the long-chain polyunsaturated fatty acid arachidonic acid, or alpha-linolenic acid to DHA. So about 60 to 7% of us in this room are people who can convert these fatty acids very actively, and the other about 30% in this room will be slow metabolizers who cannot synthesize these long-chain polyunsaturated fatty acids well. So if you have this gene polymorphisms that are determining a low enzyme activity, you have more linoleic acid in your blood and less arachidonic acid. Now, we looked at the interaction of this gene polymorphism and breastfeeding on asthma risk, and we found a very strong interaction. This is a study in Germany with a lot of babies, more than 1,000 babies, and we looked at doctors diagnosed asthma until school age, until the age of 10 years. And you see here, if you have the common allele, if you can synthesize linoleic arachidonic acid and DHA, then duration of breastfeeding doesn't matter for your asthma risk. But if you cannot synthesize these fatty acids, then breastfeeding for at least 3 months reduces your asthma risk by about half. We call this Mendelian randomization. It's like a randomized clinical trial because the genotype is distributed at random in the population. It's not related to your lifestyle choices or behavior or whatever other factors that determine asthma risk. And it shows that, yes, if you provide breast milk that has these fatty acids preformed and overcomes this metabolic weakness, then you reduce your asthma risk long term. Isn't that fascinating? So in the future, perhaps mothers will go to the drugstore, pay €100 and have a genotyping test for their baby, and then they will select what they feed to their baby because they will know the effect of feeding depends on the genotype of my baby. Maybe it's not so far away because now genetic testing becomes cheaper and cheaper. Complementary feeding and allergy risk is the last point I want to address because it's a topic where we have learned a lot more in recent years, and there's actually fascinating information here. In the past, the Americans recommended that we should avoid and delay allergenic foods given to babies. They said no cow's milk protein the first year, no eggs in the first 2 years, no peanut and fish in the first 3 years. Some families said maybe it's best to avoid peanuts until retirement so you don't get a peanut allergy, right? Was it working in the United States? No. When these recommendations were provided, you see that in the United States, the rate of food allergy and peanut allergy went up. It was not an effective recommendation. It was not based on evidence. It was based on some observational data. But now we have several randomized clinical trials that have randomized babies to earlier or later introduction of allergenic complementary foods. And you see, if you provide hen's eggs earlier, you reduce the risk of egg allergy by 44%. If you provide peanuts earlier, you reduce the risk of peanut allergy by 7%. Cow's milk, you reduce by 1/4 by earlier introduction. It is as if there is a sensitive window of opportunity in the development of the immune system. If you provide certain allergens earlier on, then the immune system is more likely to develop tolerance than if you provide the same allergen later. Also, for early introduction of fish, there is a risk reduction, although these are observational studies, not randomized clinical trial. Very impressive is a study from Norway. 2,400 newborn infants were randomized, and they were not infants with a high risk of allergy. They were infants from the general population. And they had two interventions. One was intensified skin care. You heard yesterday this hypothesis that if you have a cracked skin, then you could be sensitized through the skin. So they gave more emollients to protect the skin. And the other one was early solids already from 3 months onwards with common foods, peanuts, cow's milk, wheat, and egg. The skin care had absolutely no effect on food allergy. But if you had early allergenic solids, then at 3 years, food allergy was reduced by 60%, cow's milk protein allergy by 7%, peanut allergy by 60%. A huge benefit, huge reduction of food allergy if you introduce complementary feeding earlier. So that's really a very important finding for our practical care. So the conclusion is maybe one size may not fit all. For children who live in populations with a high infectious disease burden but a low allergy risk, for example, in many parts of Africa, clearly exclusive breastfeeding for 6 months is the best option. For affluent populations like in Europe, with low infectious disease burden but high allergy risk, the best option may be to introduce complementary feedings at some time between 4 and 6 months, including foods with high allergenic potential, along with continued breastfeeding. Clearly, we continue to say breast is best, protect, promote, and support, but we don't really have the data to say it's exclusive breastfeeding that does the trick. It's breastfeeding, the more the better, but along with timely introduction of complementary feeding is a reasonable option. So key messages for you, for practice, infant feeding has really very large and lasting effects for later health. Breast is best. We should promote, support, and protect as much as we can. Longer breastfeeding is associated with greater benefits, but there's little evidence that longer exclusive breastfeeding versus mostly breastfeeding is associated with different health outcome in infants in Europe. High protein supply in infants should be avoided. Avoid unmodified cow's milk in infancy to prevent later obesity. Complementary feeding may be started at 4 to 6 months, including foods with high allergenicity. In infants in Europe that have a low infectious disease risk but high risk of allergy, and that applies to all infants whether you have a family history of allergy or they do not. With this, I thank you very much for your kind attention on an early Sunday morning.